Okay, hi everyone. Welcome to today's Lunch and Learn webinar on Substance Use and Addiction 101. It's so great to have all of you join us today. My name is Liz, and I am the Substance Use and Addiction Partnership Manager with UBC Health and the BC Centre on Substance Use. And I'm joining from the UBC Vancouver campus, which is on the traditional, ancestral, and unceded territory of the Musqueam people. This webinar series was created to provide foundational education on substance use and addiction. And when we developed this series, we had educators and interdisciplinary clinicians in mind. However, this content is really relevant to everyone in our community. So thank you all again for taking the time and learning with us today. We'll have some time at the end for questions. So please use the Q&A function on Zoom throughout the presentation if you have any, and you can also vote on questions you'd like to see answered. Lastly, at the end of the webinar, you will be redirected to a quick survey in your browser, and we'd so appreciate it if you could take a minute to fill that out. Okay, without further ado, I'm going to hand it over to Tiffany for today's presentation.
Thank you, Liz. Thank you everyone for joining me. My name is Tiffany. I am a clinical pharmacist. I normally work out of Langley Hospital, but I am currently in the inaugural year of the BC Centre on Substance Use and Shoppers Drug Mart Addiction Pharmacy Fellowship. So this is a brand new program and I'm very excited to be a part of it. And I wanted to thank the BC Centre on Substance Use and Shoppers Drug Mart for enabling me to be involved with this amazing program. So I am calling in from Langley, BC. So I would like to respectfully acknowledge that I am a humble guest on the unceded traditional territories of the Coast Salish, the Semiahmoo, the Katzie, the Tsawwassen, the Stolo, and the Kwantlen nations. So I'm hoping throughout this presentation that you'll be able to get a better understanding of substance use disorder, how it is defined, and who can be affected by it, to have a better understanding of the current overdose crisis in BC, and to gain a better understanding of stigma, harm reduction, and trauma-informed care. So substance use is part of human history. It has been around for eons. We have been using it in religious and spiritual ceremonies dating back thousands of years. A substance or a psychoactive or hallucinogenic substance that is used in religious and spiritual ceremonies has been termed an entheogenic substance. Some examples of that are the amanita mushroom, which is that lovely little red and white mushroom there, which actually is a hallucinogen. And it's been the center of religious rituals in Central Asia for more than 4,000 years. The psilocybin mushrooms, which I think a lot of people are aware of, was used in spiritual ceremonies in Central America indigenous cultures. And of course, the peyote cactus is used by the Navajo, or the indigenous people in pre-Columbian Mexico. Substance use has been, we've been using it for medicinal reasons as well. Opium was probably our first it is our first opioid that's ever been used, and it has been described in some of the earliest written literature ever found. So even in Homer's Odyssey, they described using opium as a pain treatment. Opium is derived from the poppy flower, for those of you that don't know that. So they've been making opium for a very, very long time. Then in about the 1800s, they started putting it into an alcoholic tincture called laudanum. And this was really, really widely used during the 19th century for various conditions. And in fact, this advertisement here for Mrs. Winslow's soothing syrup was actually laudanum tinctures for children's teething, something we definitely wouldn't condone in this day and age. Recreational use, people have been using substances to have fun and to for a long period of time. So alcohol, nicotine, and caffeine are probably our most prominent examples of that. Okay. Unfortunately, with our modern age, or maybe fortunately, we have developed more potent compounds. So we have really escalated our usage of these items. So traditionally, alcohol was made from fermentation. And if you fermented starchy cereals, you got about a 5 to 6% alcohol content. If you fermented grapes, you got about 14%. But then we discovered distillation, and we've now made it possible to have drinking alcohol with strengths greater than 50%. Of course, the higher the percentage, the more dangerous it is. But yeah, as mankind, we always strive to do more. Opioids. So the original opioid was opium, and then in the early 1800s, we actually derived morphine from the opium. And then shortly thereafter, codeine and heroin were also discovered. These are all called natural opioids because they are derived from the origin of the poppy flower. But then we started making and synthesizing opioids. So it's strictly in a laboratory. And this really opened the door for more potent compounds. So oxycodone was first synthesized in 1916 and fentanyl in 1959. And there has been multitudes of other synthesized opioids since then. So it's really been in the last sort of 50 years that we've really kind of upped the potency of our opioids. Even our plants aren't immune. We have managed to breed and refine our cannabis plants to increase our THC potency. And so back in the 70s, during the hippies love fests, the traditional cannabis THC contents were about 3 to 4%. And now they actually are ranging closer to 12%. So quite an increase in THC potency. Okay. So why do people use substances? We use them for a variety of reasons. We use them to feel good. We use them to feel better. We use them to do better. So you might have a university student using a stimulant in order to stay up longer and do better on their exams. Of course, there's always curiosity and new experiences. People are always looking to try something new. There's peer pressure, trying to fit in, which unfortunately really does affect our younger crowd. And of course, there's tradition and spiritual uses. So with that, it's really important to realize that spectrum use occurs on a spectrum. Substance use occurs on a spectrum. So it can be anywhere from beneficial, so things that have positive health or spiritual or social impacts on us. So people that do use substances in a traditional ceremony, people that use them as medicinal reasons. So, they're having a positive impact without a negative consequence. And then we sort of move into the non-problematic recreational area. So, you have your beers when you go to a hockey game, but you're just having some fun, but it hasn't had sort of any really negative consequences on you. And then we move down the spectrum into our more problematic usage. And this is where you might not imbibe in a substance on a regular basis, but maybe you binge drink, or you drink and then drive home and are impaired driving. So you're starting to have some possible negative consequences of using your substances, but they aren't an everyday consuming your life type usage. And then from there, we move down the spectrum into the substance use disorder or the addiction. And this is when it becomes a habit, it becomes compulsive despite negative health and social effects. So they can't control their usage anymore, even though they may know that it's having negative impact on them. And people move up and down this spectrum throughout their lifetime. So just because you fit into one category now does not mean you're going to fit into that category later on. So just sort of keeping in mind that people can move up and down this spectrum throughout their lifetime. Okay, so how is a substance use diagnosed? So I absolutely do not expect anybody out there to be diagnosing or remembering all of this, but I just wanted to give you a bit of a what it is that a physician is looking for when they're diagnosing somebody with a substance use disorder. So the DSM-5 is basically a psychiatric handbook, and it has criteria for various psychiatric illnesses. And for substance use disorder, it has 11 criteria. And so they'll go through those criteria with a patient, and you can range anywhere from mild to moderate to severe substance use disorder. And it depends on how many of those criteria you meet. So just because you have a substance use disorder also does not mean you have a severe one. You can be on a on a spectrum of substance use disorder as well. So the 11 criteria are the substance is often taken in larger amounts over a longer period of time than intended. There is a persistent desire or unsuccessful effort to cut down or control substance use. A great deal of time is spent in getting and using and recovering from the substance. There's a craving or a very strong desire to use the substance. There is reoccurrent substance use, which results in a failure to fulfill major role obligations such as work, school, home. You have continued substance use despite having persistent or reoccurrent social or interpersonal problems caused or exacerbated by the substance use. There's important social, occupational, or recreational activities that are given up despite because of the use of the substance. So you might not be doing hobbies anymore. Maybe you stopped playing hockey, you used to do that. Recurrent substance use in situations in which it is physically hazardous. So maybe you're starting to use your substances at work and you operate heavy machinery. Continued use despite knowledge of having persistent or reoccurrent physical or psychological problems that are likely to have been caused or exacerbated by the substance. So you're continuing to use even though it's actually making you worse and causing increased problems. The next one is tolerance. So this is defined as a need for markedly increased amounts of the substance to achieve intoxication or the desired effect, and a markedly diminished effect with the continued use of the same amount of the substance. And this is a really important thing to take note of, is that persons start using substances and a small amount can give them a desired effect. And then over time, the more they use that substance, the more they become tolerant of the substance and are unable to achieve that same effect with those same doses. So then they have to increase their dose. And so as time marches on, they are actually increasing their dose in order to achieve the same effect. And in some cases, when it gets quite severe, they're actually taking these doses in order to just feel normal, because their body is so used to having it that they can't actually function without it. And so they get this tolerance in it. So it increases their usage and it becomes this vicious cycle because they need to get more and more and more and more as time goes on. And then withdrawal is the last criteria. So either you get the characteristic withdrawal syndrome, depending on which substance you're using, or you are taking your substances to avoid that withdrawal syndrome. And so that is often a case with people once they're into a substance use disorder, is that they have to keep using the substance in order to not go into withdrawal and feel absolutely miserable. And it just actually, they're not always. And I think people always think that you're taking a substance to get high, but it does get to the point sometimes with some of my patients where they're taking the substance just to function and actually feel normal and not get sick from withdrawal. Okay, next slide. So that's a lot, and I don't expect you to memorize all 11 of those things, but a little more simplified approach for some, especially if you're just, maybe trying to decide whether or not a person may have a problem, is to look at the 4 C's of addiction. So loss of control. Are they unable to stop what they're doing? Are they doing it despite knowing that they have other obligations or things that they should be taking part in? Consequences. Are they doing it despite negative consequences? Have they lost their job? Have they been in the hospital due to alcohol withdrawal seizures? But they're still continuing to use. Compulsion. So they're continuing to use despite knowing that they shouldn't be. And then lastly, cravings. And so this is both mental and physical cravings. So their body, they have the cravings where they really want to do it. And then they also have your body telling them that they need to do it in order to keep them functional. So that's just a bit more simplified way of looking at it is, is there a loss of control? Is there consequences? Do they have compulsions to take part in it? And is there cravings? So there is some things that make us a little more vulnerable to addiction. There are more than just what I've listed here, but some of these are kind of more this is some of them. So unfortunately, genetics does play a role. And we do have lots of studies to show that it can run in families, and that they're looking at certain genes to see if it makes you more predisposed to have a substance use disorder. This does not mean that this defines you and that you are doomed to have a substance use disorder if you have a family member, but it does make some people more susceptible to continue substance use if they're put in a situation as compared to somebody else who does not have this sort of family history and genetic history. Childhood and adolescent drug use. This is really important. It has been shown in multiple studies that the earlier a person uses in their lifetime, the more likely they are to develop a substance use disorder as an adult. There's multiple factors involved, and a lot of the studies kind of show different things. If you grow up using a substance, this is what you know. This is how you've coped with things. You haven't developed any other tools to cope with hard things in life. There's also, are you affecting your brain development by starting using substances earlier? And then there's also the theory on the prefrontal cortex. It is our area of our brain that really tells us when something is going to have negative consequences, and to really think about, I should or shouldn't do this. And this prefrontal cortex doesn't actually develop until our 20s. And it's even later in men than in females. And so this is often what leads to behavior that otherwise, as an adult, you'd be like, why in the world would you do that? That is completely unsafe. But in our adolescent groups, they tend to do these behaviors, and it doesn't have to be substance use related. You'll see it in all sorts of things. And it is that prefrontal cortex is not fully developed. Exposure to high-risk environments or drug accessibility. So if you grow up in somewhere like the downtown East Side, you are just overall exposed to the drug trade and to people using, and you see it, and it's in your everyday life versus somebody that might grow up on a rural farm and may not see it. So unfortunately, that can increase your risk factor of using it in the future because it is just so prominent in your life. Permissive normative attitudes to drug use. So this one's interesting, and I like to use the wine drinking housewife that you see on all the kind of TV shows and movies that they sort of make into a normal thing and an accepted thing. And then you kind of see it in your social media as well, that, people are always drinking wine to cope with the day, but it's promoted. And so you see this sometimes in especially in our legal substances, because advertisers are trying to earn money. So they're promoting lifestyle choices using some of these legal substances. Social stress, poor supports, poverty, economic barriers to treatment. So these are all factors definitely in increasing substance use. So someone who maybe, living paycheck to paycheck may not know if they have enough money to feed their children each week. They're going to have increased social stressors. They may not have a job with, I'm fortunate, I work in the hospital system. I have a job with Blue Cross. I have a job with an employee assistance program. So I have access to all these supports, whereas somebody in a minimum wage job may not have these accesses. And it really does create a barrier for them in order to either, if they're trying to use if they start using substances as a way to cope with mental illness, they don't have those resources that I might have available as somebody who has all of these extra things tacked onto my job. So economics can really play a role in barriers for treatment. And I think a prime example of that as well is that our government-funded treatment centers. I was just speaking to a physician on my last rotation, and he said they used to be much longer in duration, and now they've been cut down to about 3 months, that somebody can access a publicly funded treatment center. And he said in 3 months, these patients are just feeling comfortable in their skin, that it's not long enough. Whereas me as a private private payer can actually go and access a center for months to years if I needed that in order to become stable and work through my substance use disorder. And I like to point out that nobody ever got to using a substance use in 3 months. It took years to get there. And so we need to spend that time to help get them out of that situation as well. Trauma is a huge, huge factor. This can be, and I'm going to go into this a bit more, but it can happen at any time in their life. And talking to these patients, it can be a huge factor. And they use substances to cope with some of this traumatic situations that have happened to them. Psychiatric disorders, unfortunately, there's still a huge stigma about mental health, and people are afraid to admit that they have anxiety or depression, and they don't want to go to their doctor, and then they start self-medicating with substances in order to cope, and which is really unfortunate, because we have lots of treatment for these people, but the stigma is still quite large. This slide is just to kind of remind you that substance use occurs across our whole social spectrum, that it is not just downtown East Side. I think sometimes people get a little, a little not in my backyard. It's not happening to me or my neighbors, but it is. It's happening to people across all social and levels. And, I can name at least half a dozen friends in close family that some substance use has been a problem in their lifetime. And I think we all can. And I think if you stop to think about it, and I really just hope that people realize that it can happen to anybody, and it's not just one social class that this is a problem for. So some key points. Substance use disorder is a very complex disease that can occur across the lifetime of a person. It occurs across the whole social spectrum in every part of society, and it has physical, social, and psychological harms that need to be addressed. We can't just give somebody opioid agonist therapy and expect them to get better. We also need to address all the other parts of their social and psychological components to do treatment as a whole. So the opioid crisis in BC, this is on every news page when you pull up any of our provincial labs. And this is something that people kind of asked for more information about. So we'll talk a little bit about this. So in September 2021, the BC coroner released their most recent report. It included data up to the end of July. July, unfortunately, it was one of the second highest months of overdose deaths that BC has ever witnessed. There was 184 people, or 5.9 deaths per day. So almost 6 people per day were dying of an overdose in July. Just very recently, they actually released the numbers for August and September. August was 181 and September was 152. So we're not coming anywhere close to changing this, unfortunately. There was a 28% increase in overdose deaths from January to July 21 as compared to the same dates in 2020. So 30% more people. 72% of deaths were aged 30 to 59, and 79% of them were male. So this is a young person's disease, and it is taking out people in the prime of their lives. This chart here just shows a bit how we've gotten out of control a little bit in the last few years. So in 2016, they actually declared the opioid crisis, and you can see that there was quite a large rise in the amount of overdose deaths in 2016 as compared to previous years. And then I'm going to explain why that happened. But you can see that we actually were starting to do better we introduced a lot of resources and really started to focus on this. In 2019, we started to do better. And then unfortunately in 2020, we lost ground again. And I think some of that's COVID, some of it, I think it's multifactorial. I don't think we can completely blame COVID, but it definitely knocked out some of our resources and some of the programs we've been trying to put in place to help. This is this slide was released from CBC News, and it's actually just a projection of overdose deaths for 2021. And unfortunately, we're very likely to meet this projected result, which is more than 2,000 people in the last year have passed away from an overdose death. So what happened in 2016? 2016 is when fentanyl really started to show up in the toxicology reports, and you can see that's the dark blue line there. So it increased in concentration and number of times that it was found in these reports, and it really has stayed up there. So we haven't changed fentanyl. It has been the primary drug found in overdose deaths since about 2016. So that's really what shot it up. Now, fentanyl is 20 to 40 times more potent than heroin and 100 times more potent than morphine. So part of the reason why it's playing such a huge role in these overdose deaths is because it is just so much more potent than the original substances that the people were using. So as I mentioned, fentanyl is so much more potent than heroin and many other opioids. It is indistinguishable from heroin. So you can't smell, you can't look at it and just, see that it's mixed in with the heroin. It looks exactly the same. The thing about fentanyl is because it is a synthetic opioid, we can make it in a lab, and it's actually cheaper than heroin. So what happened was the drug dealers started cutting their heroin with fentanyl in order to increase their yield. So originally, you could get a supply of heroin and you could divide it up into 10 doses. But now by adding fentanyl, which is a much, much more potent opioid, you could sprinkle small amounts of that throughout the heroin, and you could divide that heroin into 40 doses and still have the same result as the 10 doses. And then you suddenly are increasing your yield and increasing your money. So just like any other business, it came down to money for the drug trade, and that adding fentanyl into the supply really increased that for them. The problem though, and where we're sort of at now is, as I mentioned earlier, you develop tolerance and dependency. So now people have started, getting fentanyl mixed in with their heroin, and then eventually they needed a bit more to get the same result. So then they were actually starting to seek out higher doses of fentanyl. And now when I talk to patients, they actually tell me that they're not even using heroin anymore. They're using straight fentanyl because that is where they're at. In order to get the results they need, they have to use the straight fentanyl. So they have developed this tolerance in order to get there, which is also making it more difficult for us to treat them as well, because they're using such potent opioids that providing treatments is becoming more challenging. So this is an image that really shows you the differences in the amount of product that is a lethal dose. And so when the dealers started mixing in fentanyl to the heroin, it's not done in a licensed laboratory where there's, regulated things going on. It is completely, back alley labs. And so you can see how little fentanyl you need to achieve a lethal dose, that you don't have a lot of leeway when you're mixing it into other substances. So it was really easy to accidentally give somebody too much. And it wasn't intentional. The drug dealers don't want to kill off their customers, but it's just, there's just such a small amount goes such a long way that it's really easy to make a mistake when you're doing these mixes. And so that's really what, it has been a problem. And so you can see here how little fentanyl you need in order to have a lethal dose. And unfortunately, carfentanil is now showing up in more of the screens. And it was actually, so the coroner's report had it linked, the coroner's report up until the end of July had it in 137 deaths in 2021. So we don't have the data since the end of July. But in 2020, it was only showed up in 65 of the cases. So it is actually more than doubled in 2021 as compared to 2020. And that was only with half a year's data. So we're getting these more dangerous, more potent opioids showing up, unfortunately. So COVID, yes, it definitely played a role. And I think there's several, I don't think we can blame COVID by itself for the increase in overdose deaths. but there's some possible contributors for sure. This heroin comes from overseas. It's made from an opium poppy, and it primarily came from Asia and South America. So when the borders closed, there started to become supply issues. So then fentanyl levels were starting to get increased and mixed in more with the illicit drug supply. Local resources were shut down temporarily or moved to online or telephone resources, which are not as accessible for people. Imagine somebody, who relied on some of those local resources and suddenly they weren't available for you anymore. People started using alone more frequently. They were scared of being around other people. We were told to avoid other people. And the scary part is, and what I don't think a lot of people realize, is that 80% of overdose deaths occur inside a residence. 80% occur inside. So suddenly we were encouraging people to stay away from other people, to not, socialize with anybody. And that is where these deaths occur. I think part of the reason for that is because nobody's going to come across and find you right away, as if somebody goes down on the street, there's a lot more traffic and movement around. So, it was a really an unfortunate situation that COVID really kind of isolated us. And of course, there was also the loss of jobs, isolation, and boredom. And I've heard that. I had a patient recently that told me, he used to do temp jobs and he was able to keep himself busy, and then I said, what happened? And he said, well, COVID happened. My temp jobs went away and suddenly I had nothing to do. And I slipped back quite quickly into using substances. And of course, it's not just opioids that COVID has affected. Alcohol use has increased as well. So the BC CDC did a publication at the end of June. They had done a survey and also looked at alcohol sales in BC. And they found that there was an increased consumption of alcohol. And the most common factors that people reported was stress, boredom, lack of regular schedule, and loneliness. And I think many of us saw that in friends and family. And support systems just became more difficult to access. If you were somebody that went to AA on a regular basis and suddenly that was taken away from you or changed to online or tele, we know it's not the same as in-person things. So it really kind of disrupted a lot of people's regular routines that they were relying on. Okay, so current approaches to substance use disorder. I hope you kind of are starting to realize that it's not just a physical treatment that is going to fix substance use disorders, that we have to look at it both from a health and a social point of view. So we're going to examine 3 ways of operationalizing health equity and social justice in a clinical practice in the context of substance use disorders. So the first one will be reducing stigma for people who use drugs. Stigma is a big thing. Stigma refers to negative attitudes and beliefs about a group of people due to their circumstances in life. For example, race, gender, culture, and health status. It happens when people are negatively judged and devalued because of stereotypes associated with their identity or health. It is a major barrier when people are trying to seek services and they feel labeled or judged. So I've heard this and I've seen it in my patients more than once where they've had a negative experience in the healthcare system because they felt like they were not valued, that people treated them differently or poorly. And unfortunately, it's probably true. And they don't want to interact with you anymore. And they don't want to come to the hospital because the hospital isn't a positive thing for them. And so they really don't seek out care when we hope they would. What are some things we can do and try to reduce stigma? Language really matters. So how you talk to people and what you say to them makes a huge difference. So trying to use people first language. So rather than calling them the opioid addict, then saying they are a person with an opioid use disorder. It's the same as if I said, you're the depression patient, or you're the patient that is suffering from depression. One thing is defining you. The other one is describing something that is happening to you. And which way would you prefer to be referred to? And I know we all would go with the second. Try to use language that reflects the medical nature of substance use disorders. So rather than calling somebody an abuser or a junkie, saying that they have a substance use disorder or an addictive disease, and trying not to use terms that you're trying to be medical about it. Use languages that promote recovery. So don't say a patient is unmotivated, unwilling to be involved. Try to be a bit more positive. They're not in agreement with the treatment plan at this point, but we will bring it up with them the next time we see them. You're just trying to promote future and not just negative assumptions on the patient. Avoid slang and idioms. And I think the most common thing here is to use the word clean. And I will say I was guilty of this until I had somebody point it out to me, and then I was horrified. But you don't want to refer, and patients will say that they're clean or dirty, or they won't say dirty, but they'll say they've been clean for 6 months. But we don't want to refer to somebody as being clean or dirty. We want to refer to them as being abstinent or sober. So trying to think about that in your mind, and just in how you're saying things can really affect how a person perceives. And so we have a video here just to show you how language can really affect a person.
The impact of being labeled as a drug addict, it's changed my life. No matter how hard I try to fight it and prove that I'm not using and try and make it better, it's just, there's always somebody to say, well, it's only a phase or something. They really don't believe you, right? I've been clean for 18 months now. Still hard as ever to get going, because whether you're clean or not, it's still getting treated like you're still using. It's just hard the way things work that way.
Once you're an addict, it's posted like, you don't stand a chance, really. Like I said, I've been clean for, I'm going on 4 years, and it doesn't matter. That doesn't get looked at. It just, I'm already labeled drug addict.
It's like everybody's scared to be around me. They think they're gonna catch something from me, and it closed a lot of doors. And I'm still me. I'm still that guy that has got it in him to go out and slay fish and work hard. And
people look at me as a junkie or a hoe or a drug addict or a drug dealer or dope dealer, whatever, rather than Margaret. Like, they don't see me as Margaret, they see me as a drug addict.
But people don't see it, they build up these stories or get these ideas in their head, and it's so hard to change somebody else's thought on how a person is when they're addicted. Even though I have an addiction, I like to be treated equally, just same as anybody.
Just don't give up. There's always hope.
So what can you do? So as a teacher, you are a role model, and you can directly influence change in your students and shift stigmatizing views. After this presentation, I hope you take a couple moments to yourself and be a bit self-reflective about your own biases. We all have them. We all grew up in environments where there is biases and stigma. But what you need to do is recognize what those might be and how you can mitigate them and try not to enact on them in your day-to-day life. Treat every human being with dignity and respect, just like you'd want somebody to teach or treat your family members. See a person for who they are, not what drugs they use. Listen while withholding judgment. Avoid using labels. Replace negative assumptions with evidence-based facts. Use people-first language and continue to learn. We're actually going to have a webinar on substance use-related stigma in January, so I hope you can all join us for that. Trauma-informed care, principle number 2. So trauma is an experience that overwhelms an individual's capacity to cope. It can be experienced at any stage in a person's life and can often be completely out of their control and cause devastating lifelong effects because of it. Trauma-informed services try to take into account an understanding of trauma in all aspects of service delivery and place priority on physical and emotional safety, as well as choice and control in decisions affecting one's treatment. We did have a video, but in the interest of time, we're going to skip over it, but we will add it to the comments so that you can, to the chat, so that you can have a look at it for yourself. I definitely think you should check it out. What are the principles of trauma and violence informed care? So try to build an awareness and understanding of trauma. There's actually a program from the BC Mental Health and Substance Use Services about this. In particular, you can go on their website and find it. Emphasize safety and trust. So checking in with a patient, a coworker, whoever it might be, are they feeling safe? Are they okay to talk to you where they are? Asking those questions ahead of time so that they're feeling comfortable. What can I do to make you more comfortable? Collaborate with and empower the patient. Give them voice and choice. Don't tell them how they should be, what they should do to be treated. Actually give them a chance to voice their opinion and have a choice. Always consider trauma as a risk factor, especially if somebody is just not, behaving in a way you would expect and kind of wonder, is there something else going on underneath this? Do I need to find out, is there a reason why you're acting like this? Consider cultural, historical, and gender issues, and of course, adapt your language. Try to use non-stigmatizing language on your signage and your staff, by your staff. And our last approach is harm reduction. Harm reduction is a pragmatic response that focuses on keeping people safe and minimizing death, disease, and injury associated with higher risk behavior, while recognizing that the behavior may continue despite the risks. But it creates opportunities for engagement that are critical for patient care. So BC has a huge harm reduction incentive going on. And so we supply a lot of things for safer injection, for safer inhalation, safe sex, of course. One of our more prominent things are the supervised consumption sites. So Vancouver was the first one in Canada. Insight, I'm sure many of you heard about it on the news. It was opened in 2003. So it provides clean equipment for drug consumption, all the supplies they might need. And this helps to reduce the spread of infectious disease. So when the patient is coming in and using clean supplies, it helps reduce the spread. We can test their drug contents on site so they know, if there's a high concentration of carfentanil, for example. If there is an overdose, there's an immediate response. So there is nursing on staff who are watching everybody while they're using, so that they have that opportunity to respond and respond quickly in an appropriate manner for the overdose. But it also has a much bigger role in, it's not just about having patients come and consume substances on site, but it also provides a connection for us to provide clinical care. So, you see somebody with a terrible wound and you can get them in to get some treatment, get their vaccinations done and improve community health, and make those connections to the addiction services and the healthcare services and the community services. So all these things are sort of working together in Insight to try and make those connections and provide safety for our substance users. And again, taking out that using alone component, which is what, 80% of people died inside. So taking that away and having them come to these sites, and they feel safe too while they're using. So they have a place they can recover in safety after using. I want to do a really quick plug for naloxone, and then we'll move into some questions. So naloxone is a opioid reversal agent. So it actually is an antagonist. When somebody takes opioids and overdoses, it causes respiratory depression or they stop breathing. Giving naloxone actually knocks all the opioids off the receptors and binds to those receptors instead and blocks any further opioids from trying to bind to them. So it actually reverses the effect of the opioid overdose, and it enables us to get them to the hospital and to receive further treatment. So it is super important. Next slide. So if you have any sort of clinic or I think any business actually should be carrying naloxone on their premises, because you never know when this is going to happen. If you're going into people's homes or patients' homes, you should carry a naloxone kit with you, so that, because it is just so life-saving, and it's so easy to use. It's great to sort of develop a response plan with your particular work or practice and try to make sure people understand how to use it, what it's used for, and where it's located, and to always have some on the premises. There is the next slide has a bunch of videos that can just give you a really quick, it takes 6 to 12 minutes, not a long investment in time, and shows you how to use the naloxone kits, but they are super easy and meant for anybody to be able to use them. So I highly suggest you watch a video on naloxone and get a naloxone kit for your work or clinic if you don't already have one. Okay, so some resources here. We went through a lot. A lot of this information is actually involved in the Addiction Care and Treatment online course. It is offered through the BC Centre of Substance Use and UBC. It is a free course. It is meant for everyone. It's not just for doctors or nurses. I think some people felt that they weren't, they couldn't take it, but it is not. It is meant for everybody, and it is a really good overview on addiction care. The Provincial Opioid Addiction Treatment Support focuses more specifically on opioid agonist therapies. Again, that's the BC Centre on Substance Use and UBC, and again, free. These both are work at your own pace. You can do it whenever you have the time. Towards the Heart is a BC website, and it has lots of harm reduction, and the naloxone training is on there. If you want to learn more about trauma-informed practice, the BC Mental Health Services website, as I said, is a great place to go. And of course, next slide, the BC Centre on Substance Use has lots of links to some of these things, as well as so they provide a lot of training, education, as well as they do a lot of research, and very big contributors to a lot of the care guidances that we are coming up with in BC. So great website to start and sort of get information from. Our government of BC has overdose prevention and response information. And of course, your local health authority, every single one of them. I went to every single one of their websites. They all have local information for substance use disorders and treatment. So if you need something maybe a bit more specific to your geographical area, try your local health authority. If you are actively involved in prescribing or dispensing OAT therapy, the Addiction Medicine Clinician Support Line can really help make some clinical decisions, and they're available 24/7 to help out, because we know not everybody is an expert.
So, I know you're in your addiction fellowship training right now to be an expert in the field of addiction medicine. But I was just wondering, what is something that you wish you maybe had learned earlier in your career or your training about substance use or caring for people who use substances?
I wish I had learned more about the people behind the substance use disorders. That so much of my training focused on the treatment side of things that I never really saw the people behind the substance use disorders. And now that I'm much more involved and taking an active approach, and just honestly, they're your best teachers. So if you have questions, often they are willing to share and talk about it. And I'm learning a lot of my street lingo and things like that from my patients, and they have been my best educators. So I wish I had more emphasis put on the people behind the substance use.
Thank you. Yeah, they're definitely the experts in their own care, for sure.
Mm-hmm.
I see a question in the Q&A. So can you please can explain the difference between nasal spray naloxone and injection naloxone?
Yeah, it's just an administration technique. So they both have the same effect. In Canada, the nasal wasn't available for the longest time, and somebody else might actually be able to answer this better on if I think it's just sort of coming out now. But they both do the same thing. It's just people aren't always happy with handling a needle and administering a needle, whereas squirting a nasal spray up somebody's nose is a lot easier for somebody to respond to, especially a layperson who's really not comfortable with using an injection. But we did start with the injectable naloxone, and that's still the primary one in the kits, just more due to a supply component. But the nasal's out there, and hopefully that will actually become the more prominent thing, because it takes away the having to use a needle.
And I'm just seeing someone in the Q&A also saying there's a big difference in the cost. So nasal spray is much more expensive.
Yeah, for sure. And that's really what's been the limiting factor in bringing it to the main usage.
I'm curious as to what the current drug awareness curriculum today's youth are exposed to looks like. So it looks like for teenagers.
You know what? I would be interested about that as well. And it's funny because I just went on a field trip yesterday with my young son to a grade 9 class at Walnut Grove Secondary. And I was surprised and impressed when I walked through the front doors that there was actually a large poster on the wall about drug use and stopping overdose deaths. So I was very happy to see that the conversation is occurring out there. I don't know if that is across all high schools and stuff, but I was, impressed to see that and thought that was great. I wanted to remind everybody that the substance use and stigma webinar is coming up in January. So we would love to see you there and get a bit more in depth into stigma and the effect that it can have on our populations.
Yeah, thank you so much, Tiffany, for this great presentation, and to all of you for attending in the audience. I hope you found this informative, and like Tiffany, I hope to see you at the next webinar. Please register using the link in the chat. And a final reminder that you will be redirected to a short survey in your web browser. So thanks in advance for sharing your feedback. Have a great afternoon. Bye, everyone.